Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will be dealing with some of the clinical scenarios each one of you will be facing when you start dealing with the patients. One day in your clinic, you will be having 2 or 3 patients coming with different complaints. Common to all of them is that they complain of swelling of lower limbs or feet. The first one can be an 60 years old man, gentleman, complaining of swollen feet and difficulty of breathing. The other, or the second one, can be a 40 years old woman, complaining of swollen feet, which makes it hard for her to keep one size of the shoe, always have to change over the last few months. And the last one can be a young male, say 20 years old, complaining of swollen feet, but in addition, swollen eyelids when getting off sleep in the morning. All these 3 scenarios include swollen feet, but the cause can be completely different in each case. Our job always is to decide what is the underlying cause so that we can correct it and help our patient. Our mission today will be discussing how swollen feet, or what we call the edema of the feet, is developed and why, and how to recognize the cause and to go for the proper treatment and help the patient, as our duty is always calling us to do. So, to understand better what we are going to discuss today, it is advisable to review our last lecture discussing the osmotic pressure and osmolality. If it's not already seen by you, you will find the link below this video. You can go and watch it, then come back to watch this one. Actually, the control of the passage of fluid from the capillaries to the interstitial space is simply controlled by a combination of mainly 2 factors. Within the capillary, we have what is called the capillary pressure, or the hydrostatic pressure. This is the pressure exerted by the fluid on the capillary wall, which tends to push the fluid out of the capillary to the interstitial space. The second factor within the capillary is the plasma colloid osmotic pressure. Colloid means that it is due to plasma protein, the most important of which is albumen. This albumen generates, as we explained in the previous lecture, what is called oncotic or osmotic pressure, which tends to move the fluid or the water from the interstitial space to the capillary lumen. It is opposing the capillary hydrostatic pressure. And the net result between them, the difference between the capillary hydrostatic pressure and the plasma colloid osmotic pressure due to albumin, will decide if the fluid will move out of the capillary to the interstitial space, what we call the filtration, or the fluid will move from the interstitial space to the capillary lumen, what we call absorption. So the forces controlling, as we have said, the fluid passage from the capillary to the interstitial space are simply hydrostatic pressure from the capillary lumen, opposed by the osmotic or oncotic pressure, which represents the osmotic force created by albumin. Now, we have what we call the filtration and what we call absorption. Actually, filtration defined by the movement of fluid from the plasma into the interstitial space, while absorption is the opposite. It is movement of fluid from the interstitial space into the plasma. If we look at this figure, it is very nice, showing that this is a segment of the capillary. Here on the left side, this is the blood flow from the arterial side, from the arteriole, and at the other end, this is going back to the venule. We'll notice here that the hydrostatic pressure at the arterial or arteriolar end of the capillary is about 35 millimeter mercury, opposed by an oncotic pressure or osmotic pressure of only 25 millimeter mercury. Thus, the upper hand here for filtration, because the hydrostatic pressure is higher by 10 millimeter mercury than the oncotic pressure. So, net fluid will pass out of the capillary into the interstitial space. This is the process of filtration occurring at the proximal or the arteriolar end of the capillary. The situation becomes completely different at the venular end or the distal end of the capillary. Because at the proximal end, as we have just explained, there is fluid leaving the capillary to the interstitial space, the hydrostatic pressure becomes less than it is. Actually, at the venular end of the capillary, hydrostatic pressure now not 35 as before, it is only 15. And still the oncotic pressure of the plasma protein, mainly albumin, is 25. So at the distal or venular end of the capillary, the force or the difference between the hydrostatic pressure and the osmotic pressure is in favor of absorption of fluid. Actually, we have now oncotic pressure about 25 minus 15 is hydrostatic pressure. So we have a net 10 millimeter mercury, which tends to reabsorb the fluid at the venular end of the capillary. So this is a sort of summary for what we have just said, that we have four forces: hydrostatic pressure in the capillaries, oncotic pressure in the capillaries, opposed to some extent by hydrostatic pressure in interstitium, which is most of the time is small to the point that it can be neglected, and the oncotic pressure in the interstitium, which is the same. That's why the main factors affecting the filtration and the absorption of fluid is governed by the hydrostatic and oncotic pressure within the capillary, as we have just explained. Now, we got what is called the Starling equation, which try to give the result for these acting forces. The flow of the fluid will be equal to the result of a constant. In this case, a constant which represents mainly the permeability of the capillary membrane. We will hear much more about capillary membrane later on in this discussion. And this is, as we see here, there is a sum of the hydrostatic pressure in the capillary plus the oncotic pressure in the interstitial space. Why we add here the oncotic pressure in the interstitial space? Because they are acting in the same direction. The hydrostatic pressure is pushing fluid out of the capillary, while the oncotic pressure of the interstitial space is pulling fluid from the capillary to the interstitium. They are working in the same direction, submitting to each other, increasing the force, pushing the fluid out of the capillary to the interstitial space. Against this force, against this summation, we have another force. This is the hydrostatic pressure in the interstitial space, which tends to push fluid from the interstitial space back to the capillary, and the oncotic pressure within the capillary, which at the same time pulling the fluid from the interstitial space to the capillary. The net result, or the difference between these two forces, decide in which way the fluid will move out of the capillary or inside the capillary. Usually, if we got a positive value for this equation, this means filtration, fluid moving out of the capillary to the interstitial space. If it is negative, it indicates an absorption. But we must notice, as explained in the previous figure, that the filtration and absorption is occurring all the time in the same area, but filtration mainly in the proximal part of the capillary, absorption is happening in the distal part of the capillary. Come now to lymphatics. Because usually, as we said, in the capillary, there is a filtration of fluid at the proximal end and the reabsorption of fluid at the end. But not the exact amount filtered is reabsorbed. Usually about only 90% of the filtered fluid is reabsorbed at the distal end of the capillary. About 10% is left in the interstitial space. So to prevent the accumulation of fluid in the interstitial space, this is the role of lymphatics, which will drain this extra 10% back to the bloodstream, and it will join the blood circulation at what we call the thoracic duct, which joined to the subclavian vein on the left side. And actually, in this figure, you will notice what we've just explained about the proximal end of the capillary with net filtration and the distal end of the capillary with net reabsorption, with the left 10% which is moved out by means of the lymphatics. So as we can see in this figure, there is always accompanying lymphatics to the net of capillaries. We can see here in green, of course, the red one are the capillaries, which lie between the arterioles and the venules, and each of them we have lymphatic vessel running to drain the extra 10% we talk about so that it will be returned back to the circulation. Another very important function of the lymphatics is to drain any proteins which is present in the interstitial fluid to be retained back to the circulation, preventing its loss. Now come to edema, or the accumulation of fluid in the interstitial space. Actually, we'll be discussing two types of edema, peripheral edema and pulmonary edema. The peripheral edema, which you can detect in the feet or lower limbs, are present in two types. The first we call beating edema, because pressing the affected area, especially over a bone, like at the malleolus or at the lower end of the tibia, with a finger, result in a visual indentation of the skin that persists for some time after the digit is removed. And this type important to recognize because usually it responds to diuretics. If you look at this photo here, you will notice that there is bilateral edema, bilateral indentation left after some pressure over the lower limb. This is what we call the beating edema. In non-beating edema, there is no persistent visual indentation since the interstitial oncotic forces are elevated. Proteins are increased in the interstitial space in this type of edema, as most of it is due to the obstruction of lymphatics. Remember, we just said that lymphatics are responsible for returning proteins which is present in the interstitial space. If there is an obstruction of the lymphatic vessels, then proteins are retained, which tends to induce what we have a sort of solidification of the interstitial space. That is why it is non-pitting. You press, there is edema, there is a swelling, but you don't leave an indentation in this area. This is very important to differentiate since the cause is different. In this picture, as we can see, we have an example, what we call the elephantiasis. The left leg is normal size, the right leg is much swollen. If you press in this swollen leg, you wouldn't get any indentation. You will leave no trace. This is a non-beating edema. Now, let's go to the main causes of the edema in general. We said before that the most important factors or forces controlling the passage of fluid from the capillary lumen to the interstitial space is the hydrostatic pressure. So if we have an increased capillary hydrostatic pressure, as can happen with cases of congestive heart failure or cases of volume overload in general, there will be edema because the hydrostatic pressure is increased, overcoming the oncotic pressure of the capillary, moving fluid much more inside the interstitial space. The other important factor we mentioned is the oncotic pressure of the plasma protein, mainly the albumen, which will tend to prevent fluid passing from the capillary to the interstitial space. If the albumen is decreased, as in cases of liver cirrhosis and hepatic failure, then this oncotic pressure is decreased, and the fluid tends to move out of the capillary lumen to the interstitial space. Another reason for hypoalbuminemia, besides the liver cirrhosis and hepatic failure, is the nephrotic syndrome, in which the albumin is lost in the urine. The third and most important cases, especially in ARDS, we'll be talking about shortly, the increased capillary permeability. Under certain conditions, the capillary permeability is increased, mostly associated with inflammation and the release of cytokines, or under the effect of toxins which can damage the capillary wall and the result of leakage of the fluid and the leakage of the proteins inside the interstitial space. The fourth cause can be increased interstitial oncotic pressure, meaning a sort of increase of the proteins in the interstitial space, and there is a specific cause for this, cases of hypothyroidism. Because actually in such a condition, there is an accumulation of mucopolysaccharides in the interstitial space, which generate oncotic pressure inducing swelling or edema. The last and important cause is the lymphatic obstruction, as we said. Lymphatic vessels are responsible for removing 10% of the filtered fluid in the interstitial space, and most important, responsible for removing proteins from the interstitial space, returning all back to the blood. If lymphatics are obstructed, then you got non-beating edema, as there is a sort of solidification of interstitial space. Now we come to the other type of edema. Besides the peripheral edema is the pulmonary edema. Actually, edema in the interstitium of the lung and the alveolar sacs interferes with gas exchange, causing hypoxia and hypercapnia, which is very serious and can be fatal. If you look at this figure, you will notice that on the left side we have a healthy alveoli. The alveoli completely free of any fluid. It is only containing air. This is the area where there is exchange between the capillary blood and the alveolar sac, getting oxygen and removing carbon dioxide. On the right side, in a case of pulmonary edema, we have got fluid in the alveolar sac, preventing this gas exchange, inducing hypoxia and hypercapnia in severe cases. As regards the pulmonary edema, we have two types. What we call the cardiogenic pulmonary edema, in which there is increased left atrial pressure, as in cases, for example, of mitral stenosis, of cases of left ventricular failure, which result in increased venous pressure, which increases the hydrostatic pressure in the capillary, in the capillaries of the lung, forcing fluid out of the capillaries to the interstitial space of the bronchioles and to the alveolar sac, inducing a pulmonary edema. In such a condition, the main complaint of the patient will be shortness of breath, what we call dyspnea. And the specific type of dyspnea is orthopnea, in which there is dyspnea or shortness of breath when the patient lies down, when he lies flat and is relieved by sitting up. Actually, this is due to the effect of gravity. When the patient lies down, the gravity effect, which prevents the return of fluid to the lung, is removed and more fluid go to the lung, and there is increase of the pulmonary edema. And sitting up will reverse this effect. Here we have what we call the elevated pulmonary wedge pressure, which will confirm our diagnosis. Let's see what about this wedge pressure. If you look at this figure on the left side, this is actually, we divided here the heart into its two parts, into the right side and the left side. In the right side, we have the right atrium and the right ventricle, and the left side, we have the left atrium and the left ventricle. In cases of cardiogenic pulmonary edema, there is an increase of the pressure in the left ventricle and in the left atrium, which is reflected back to the capillaries in the lung, and the pressure is high. How to detect this? By means of a catheter, which is introduced through the superior vena cava, traveling to the right atrium, and again through traveling to the right ventricle and through to the pulmonary artery until it is wedged in place in the capillary lumen. With a manometer at the end of this catheter, we can measure what now we call the pulmonary wedge pressure. Because as we explained, the left atrial pressure is high. In that condition, the wedge pressure will be high. This is very important to differentiate this type of edema, pulmonary edema from the next type. And actually the cardiogenic pulmonary edema, since it's due to of excess fluid in the lung, can respond nicely to the diuretics. Diuretics will have different types working at different parts of the kidney. Inducing in the final is excess removal of sodium and water from the body, decreasing venous return, decreasing the congestion of the lung, improving the symptom of the patient. The other type of pulmonary edema is called non-cardiogenic pulmonary edema. It is due to increased permeability of the pulmonary capillaries, leaking fluid and protein in the alveoli, preventing gas exchange. One famous and common example of this is the adult respiratory distress syndrome, or ARDS. Actually, there is direct injury of the alveolar epithelium or primary injury to the capillary endothelium. In both conditions, there is damage of the pulmonary capillaries. Most common causes are sepsis, bacterial pneumonia, trauma, and gastric aspiration. Common to all of these conditions is the release of cytokines, which induce damage of the pulmonary capillaries, leaking fluid inside the alveoli, preventing gas exchange. The clinical signs are severe dyspnea of rapid onset, hypoxia, and diffuse pulmonary infiltrates, leading to also respiratory failure. Such respiratory failure, usually there is hypoxia, this is decreased oxygen in the blood, and hypercapnia, that is increased carbon dioxide in the blood inducing respiratory acidosis. Actually, in this figure you can see on the left side we have a normal healthy alveoli completely free of any fluid. While on the right side we have here a case of ARDS with fluid filling up the alveoli, preventing gas exchange. In this figure, which includes one big alveolus, showing on the right side the healthy alveolus, again, very few cells, only the type 2 pneumocytes and the pulmonary macrophages, but no fluid at all. While on the right side, we have alveolus from a case of RDS. There is protein-rich fluid leaking and filling up the alveolus, inhibiting the gas exchange. This we can see clearly in this X-ray again. On the right side and the left side, we have a normal healthy lung, all aerated, that's why it looks black. While on the right hand side, we can see the infiltration, the consolidation of the lung, mostly bilateral, due to this presence of the fluid in the alveoli. Now, fluid accumulation here is a result of the loss of the epithelial integrity of the pulmonary capillaries. In addition to the fluid, there is excess protein in the fluid in the alveoli, which inactivates surfactant, the substance which is responsible for decreasing surface tension in the alveoli. This results in reduced lung compliance. Elasticity of the lung is decreased, make it more rigid. And in this condition specifically, the pulmonary wedge pressure is normal or low. Remember, cardiogenic pulmonary edema, in which the left side of the heart has higher pressure reflected on the pulmonary capillaries, will have a high pulmonary wedge pressure. While the non-cardiogenic pulmonary edema, the hydrostatic pressure within the lung is normal. That's why the wedge pressure will be normal. The main problem here is not excess hydrostatic pressure. It is the damage of the pulmonary capillaries leaking the fluid inducing this problem. This concludes our discussion for today. I hope it is clear. Any comment or questions are welcome. I will be answering. We should be communicating for need of any subjects to be explained in coming up lectures. Hope will be following for the next lectures to come. And thank you very much for your attention.